So good evening. Thank you all for coming tonight. I'm Paxson. Really happy to see you. And I want to welcome you to the Presidential Faculty Award Lecture. And I think I'm really looking forward to this presentation. So thanks to Jen for doing it. So this evening, it's my real honor to recognize the recipient of the Spring 2025 Award, Jen Nuzzo. And as many of you know, Jennifer is a professor of epidemiology. She's the director of the relatively new Pandemic Center at Brown. Thank you. And this center opened in October 2022 with the goal of focusing on one of the most urgent, and still I would say, urgent public health and national security challenges of our time. So her lecture, which I'm looking forward to, is called Pandemic Proofing the Future. Incredibly timely topic, particularly in light of the increasing concern that we're seeing around bird flu. So a little bit of background. I established this lecture in 2013, and the idea was really to recognize members of Brown's distinguished faculty, some who've been here for a long time, some who are relatively new, but all of whom are conducting especially notable, innovative, and high-impact, important research and scholarship. Recipients of this award are invited to give this lecture. It happens twice a year. And I think of it as an opportunity for faculty and students and staff, people from our community, to learn about the work that their colleagues are doing. And hopefully, at least some of you come from fields outside of public health, so you're getting an opportunity to learn about work that maybe you wouldn't hear about every day in your own departments. So Jennifer exemplifies academic leadership. Among many other accomplishments, she's co-led the development of the first ever Global Health Security Index and founded the Outbreak Observatory, which conducts operational research to improve outbreak preparedness and response. So tonight she's going to be addressing how we can prevent and reduce vulnerabilities and increase resilience to pandemics and other biological emergencies. So I'm not going to do the full introduction. I've invited Francesca Baudouin, Academic Dean of the School of Public Health, to introduce Jennifer. So please join me in welcoming Francesca. Thank you.
Thank you, President Paxson. Colleagues, good afternoon. Thank you, ICERM, for hosting us in this beautiful space. It is my great pleasure to introduce to you Professor Jennifer Nuzzo, recipient of this year's Presidential Faculty Award. The School of Public Health is so incredibly proud of your work, and this honor is really fitting of your accomplishments, particularly as tomorrow marks the 5th anniversary of the WHO declaration of the COVID-19 public health emergency. And while that is a chapter we all very much hope to close, Jennifer and her team are writing the next chapter, which hopes to be much more optimistic. For a little bit of levity, I told Jen this was like, I kind of wanted this to be part roast, part introduction. I couldn't help myself by asking our friend ChatGPT what it would have to say about my esteemed colleague. And when I put the query in, I said, can you also make it witty and a little bit endearing? And what it produced was, Jennifer Nuzzo is a public health powerhouse. If you are lucky enough to hear her speak, you might just leave thinking, wow, she made that seem absolutely terrifying and completely understandable. And I have to say, the machine was on point. And by day, this powerhouse is a professor of epidemiology and director of the Pandemic Center. And she was also one of the first faculty recruited when I was chair in the Department of Epidemiology. And I remember saying to my colleagues at that time, this was still kind of early days of the pandemic, do you know all that really cool work that's coming out of Hopkins? Like, that's hers, and now it's ours. And truly though, she has built a fantastic team, and here at the Pandemic Center, many of whom are here today. And she is an internationally recognized expert. She is world renowned in global health security, and I don't say that lightly, and pandemic preparedness and response. And the response piece is so very important. And the work that she does helps us build resilient systems, resilient healthcare systems to emerging infectious diseases, but other public health emergencies. And if you have turned on any number of media outlets, CNN, MSNBC, ABC, picked up the Post, the New York Times, basically if you have not lived under a rock, you have seen her expertise. In fact, during the pandemic, she was such a widely sought after expert that Sacha Baron Cohen tapped on her, as some of you are chuckling, you're like, I know that name, tapped on her to be a COVID advisor for the making of the Borat 2 movie. And not only trusted by Borat, she is one of the most trusted voices in medicine and public health. And I almost can't emphasize that enough in a time when science, knowledge, and information are threatened. Jennifer is doing the work to earn back the trust of public health. She was just elected into the National Academy of Medicine. This is a remarkable accomplishment. And on the, recognizing some of the work that Chris mentioned, the Global Health Security Index, Outbreak Observatory, and so much more. In the early days of the pandemic, she was one of the first people to call attention and raise alarms to a mysterious viral pneumonia in China, months before the WHO declared a pandemic. And she is still doing that work today. And this is part of what makes her work stick out. She is not just an observer to public health challenges. She has been out on the front lines, actually doing the work and building resilience, and reducing our vulnerability. And she is an innovator and very entrepreneurial in a way that I think we don't do enough of in public health. She sees problems, develops solutions, and makes them happen. And if you haven't done so already, I will put in a little plug for the Pandemic Center tracking report in their newsletter. Sign up. Each week the report publishes information on domestic and international infectious diseases. And with the slowing of federal communications, this report has become a key source for external audiences like journalists, healthcare professionals, and policymakers. And I just want to close by saying, beyond all of her scholarship, which I could continue to gush about, but will not, Jen is a total force in the School of Public Health. She is an exceptional colleague, a generous mentor, and a leader who lifts up those around her. And we all the time, we like to walk around and say, learn public health by doing public health. This woman learns public health and does public health, and is such a fantastic example for all of us. So in today's lecture, we're going to talk about pandemic proofing the future, which is maybe like a tad terrifying, but it's also going to be fantastic. So without further ado, please join me in welcoming Jennifer Nuzzo.
Thank you so much, Francesca, for that truly extraordinary. I held my breath a little bit with the ChatGPT. The Google AI feedback says that I'm a journalist at the New York Times. So I didn't want you to think I have a secret double life as a second career. That was really very kind and very welcoming. It is such an extraordinary honor. Thank you, President Paxson, for this honor. I feel honored to be here with you today, but also deeply honored to be here at Brown. I'd also like to thank a dean of School of Public Health, Dr. Ashish Jha, who frankly was one of the beacons of hope for me during the pandemic. We often were put together on panels or interacted on various different types of public-facing talks, and you were always the voice of reason and always the voice of pragmatism at a time when there wasn't enough of that going around. And when I was thinking about how do we possibly come back from this truly devastating event, how do we build something that's better, it was the conversation with you about what we should do differently that led to my coming here and building the center with you and your team. And frankly, I am so grateful, as someone who's worked on pandemic preparedness for my career, to have the blank slate in this very fertile ground to be able to build something. So really thank you to your vision and your leadership and your allowing me to come here. I am going to talk about pandemic proofing the future. And I have to acknowledge the fact that we both want to forget what has happened. But also, it is impossible to do that, particularly this week, which, as Francesca said, many people observe as the 5-year anniversary of the COVID-19 pandemic. So while I promise you we are going to end on a hopeful note, we have to look at what has happened, because we can't possibly have hope and build better unless we understand what we did wrong. And for me, nothing feels worse about the last 5 years than looking at this picture. So I got my start in public health as an epidemiologist in New York City, actually in the aftermath of another very traumatic event, September 11th. So for me, in the early days of COVID-19, when I saw this picture of a nearly empty New York's Times Square, that for me was when I thought, that's it, we failed. We failed. It should not have come to this. This was a sign of not having done what was necessary. Now, I'm not going to say that it wasn't necessary at the time, but it shouldn't have gotten to this point. There was a lot that we got wrong about COVID-19. I think nobody in this room doesn't believe that. And this, I think, is one particularly contentious point. But I would argue that one thing that we also did wrong that doesn't get enough attention, and that frankly we are still doing, is to equate this event, to call it a once-in-a-century pandemic. Those comparisons abound, and those comparisons are there in part because there are some similarities. The 1918 influenza pandemic, like COVID-19, was profound in terms of its tolls. The death toll and disruption in 1918 was truly extraordinary. Some people just do the rough back of the envelope, comparison of deaths and say, well, COVID was worse. I just have to remind you that the size of the global population in 1918 was much smaller. So this was a truly, truly historic event. But COVID-19 was profound in terms of its impact. And there's many ways to look at it, but I think one of the clearest is to look at life expectancy. We saw historic declines in US life expectancy during COVID-19. We saw a reduction of life expectancy to levels that we hadn't seen since 1990. We had never before seen such a precipitous drop since 1920. So truly extraordinary tolls. It wasn't just the United States. Across the globe, countries similarly experienced profound health tolls and a drop in life expectancy, eroding on average a decade's worth of progress across the globe. And we know that the harms of the pandemic aren't just restricted to the direct effects of the virus and the indirect health effects due to the disruption that the virus caused. We know that pandemics not only affect all of health, but they touch all of society. And so the tolls in terms of society, in terms of our economy, in terms of our politics, we're still trying to figure it all out in terms of what happened. But I have no reason to believe that they aren't similarly profound. And just today, I don't know if you read the New York Times, but today in the New York Times, there were some really, I think, engaging charts, 30 charts that showed how COVID changed everything. And I looked through those charts, and I pulled out for me the ones that really touched my heart. The first one on the left is the decline we have seen in vaccinations against measles among US kindergartners. And at a time when the United States is battling a very large and growing outbreak of measles, this, I think, really jumps to the front of some of the obvious harms that we saw during the pandemic. Very recently, we experienced the first, possibly the second, death to measles in this outbreak, which would be the first time in a decade that the United States has seen a death due to measles. As a mother, I'm touched by this, but I'm also touched by the chart on the right, which is the profound loss of educational attainment that our kids experienced during the pandemic. And knowing as a public health person that education is a very important social determinant of health, this is a crisis. But it's also a crisis for our economic prosperity. And although there have been some improvements, just looking at the scale of the loss, those improvements aren't coming fast enough. But just because COVID-19 and the 1918 pandemic and other serious infectious disease have harmed society in profound and multiple ways, calling these two events once-in-a-century pandemics are, I think, wrong for another reason. It gives the sense that not just talking about their tolls, it gives us the sense that once the event is over, another one won't occur for another 100 years or so. And this is an educated audience. I'm pretty sure most people here better understand statistics, and that is not how statistics work. But nonetheless, I think if you talk to a lot of people, that is what they believe, that we got through it, it was awful, but now we don't have to deal with another one in our lifetimes. That's just not how it works. The end of one emergency doesn't end all emergencies. Risks decline when we either eliminate hazards or reduce vulnerabilities. If you study risk assessment, you know that simple formula. And I'm going to use an analogy here because often when I talk to people, because these events are sort of invisible in most cases, they don't really get that. But I'm going to use another analogy here, and I'm going to talk about floods. It is clear that the frequency with which we are seeing floods is increasing. There's a lot of reasons for this. I'm not a natural hazards expert, but we think that climate probably plays an important role here. Our vulnerability to floods, so the hazard of floods is increasing. Also, our vulnerabilities to floods are increasing. So the overall risk of flooding is increasing. The same thing is happening with infectious diseases. So while I think most people wouldn't argue with me when I say we are seeing more and more floods, that the risk of a 100-year flood is increasing, that we are now seeing them more like one to every year to every 30 years, depending on where you are. There's some data here showing that. I think it's still a little bit hard for people to understand that in the context of infectious disease emergencies. But since the end of the COVID emergency, we have seen a steady stream of infectious disease emergencies. So last year, the WHO declared the second global emergency declaration for Mpox. That was the second time in a year that it had declared an emergency declaration for Mpox. We are seeing an extraordinary expansion of these cases in many, many countries, including potentially a more severe form of Mpox. Currently, Tanzania is experiencing a deadly Marburg outbreak. High percentage of all the cases they found so far have died, suggesting that there's more cases that they're not fighting. This is following another outbreak of Marburg that was successfully contained in Rwanda, but was Rwanda's first outbreak of Marburg. There's currently an Ebola Sudan outbreak going on in Uganda. Uganda is no stranger to Ebola outbreaks. It is one of the countries that is often highlighted as responding quite well to Ebola, but Ebola Sudan, unlike Ebola Zaire, does not have a licensed vaccine, so controlling this is quite difficult. And although we don't know for sure, but I'm sure Greg will tell us, I am sure interruptions in US foreign assistance is not making response to this outbreak any easier or swifter. The United States, as President Paxson referenced, is currently experiencing deeply concerning outbreaks of highly pathogenic H5N1 avian influenza. For me, this is one of the threats that's at the top of my worry list. This has been a virus that we've been tracking since the late 90s. We had very acute concerns about its pandemic potential about 20 years ago because we were seeing a really rapid expansion in terms of outbreaks that were occurring and a very high death rate. About 50% of the cases were dying. And there were lots of reasons to think that it could be the next pandemic threat. Fortunately, that hasn't happened yet. But in the last year, we've seen a real rapid expansion of not only the geography in terms of where this virus is showing up, but the species range, including outbreaks on farms in the United States and the first ever documentation of infections in cattle, in dairy cows. mammals that humans have close contact with. Now, this virus can't yet easily infect people, and it can't yet spread between people. But were it to gain those abilities through some not well understood mechanism, but I would argue still a very biologically plausible mechanism, it would start another pandemic. By definition, it would start another pandemic. But this virus doesn't have to start a pandemic to not be a problem, because people are getting sick today, and people are dying, and people are being hospitalized. So this is a worrisome virus in itself, and it is something that we are not doing enough to protect the people who are being exposed to it, which still today are people who work on farms. It is popping up all over the country, and so far in the United States, there have been 70 identified cases, mostly in people who have had exposure to infected animals. Some people have not, and though those are the minority of cases, it does raise questions about what's going on with this virus. I remain quite worried about this situation because it just seems to be getting worse. It is not getting better. So, as you can see, the ending of the COVID-19 pandemic emergency did not pause the stream of internationally significant infectious disease outbreaks. And just like floods, the threat of infectious disease outbreaks is increasing. And as this chart shows, this trend has been happening for decades. Changes in our environment and our behavior are giving rise to new human disease threats and resurrecting old ones. And at the same time that these hazards are increasing, so too are our vulnerabilities to infectious diseases. So we're unfortunately living in an age of infectious disease threats. So rather than viewing events like COVID-19 as a one-off, we need to start preparing for infectious disease emergencies like the recurring hazards that they are. We don't stop trying to learn about how to hurricane-proof our cities after a hurricane happens, right? We need to do the same for infectious disease. Now, this may be very depressing, right? This is the depressing part of the talk where you're like, oh, COVID was the worst. I don't want to do it again. I don't want to do it again either. And I think it is possible, well within our reach, to make sure we don't have to do it again. Preparing for infectious disease threats as though they are recurring hazards and not a once-in-a-century freak occurrence does not have to mean living in a perpetual state of emergency. It means finally doing the work to understand these threats and our vulnerabilities to them. And that may sound hard, but it is not in the realm of the impossible. It is entirely within our reach to take pandemic threats off the table. It is entirely possible to pandemic-proof the future. My husband works for NASA. And so through that interaction, I have seen what is truly possible and accessible to humans when we put our minds to things. And this is not, sending a rocket to outer space. This is not putting people on the moon. This is far more achievable. All we need to do is work systematically to understand what it takes to prevent outbreaks from becoming pandemics and to reduce our vulnerabilities. Again, it's not easy, but not impossible. And I would argue that we at Brown are well positioned to lead these efforts. The Pandemic Center that we founded just a couple of years ago is working to do that. And you can see here our mission statement. So we are leading research, education, and outreach to policymakers, practitioners, and the public to understand what it takes and to implement the solutions to prevent outbreaks from becoming pandemics, and in the meantime, to reduce our vulnerabilities and increase our resilience to these biological emergencies so that we never again have to let them upend our lives in the way that COVID-19 did. So I want to tell you about some of the work that's ongoing here because truly this is a team effort. And the reason why I am here at Brown, why I upended my family and moved them up north, besides the lovely oceans you have here. The winter's not so great, but the scenery is wonderful. The reason why I am here is because this is truly the innovation lab. This is truly the fertile ground. The recipe for doing this exists here at Brown in part because of this incredible interdisciplinary culture, this incredible spirit of people who are just willing to talk to each other and to roll up their sleeves and to figure out how to apply your skills in collaboration with others to fix these problems. So I'm going to talk to you about some of our work. First of all, as mentioned, one of the co-leads of the Global Health Security Index, and the reason why we're doing this project is we are trying to understand what matters in preparing for pandemics and other infectious disease emergencies. And what our work is showing, I'm proud to say, is that preparedness actually matters. Now, this shouldn't be controversial. If you know anything about public health, you should say, of course, preparing for something is better than not preparing for something. But at the start of COVID-19, there was this sense that if you just looked at the numbers of cases and deaths, it looked like the better prepared countries were faring worse. The reality is the better prepared countries had more tools to count cases and count deaths, identify cause of deaths. And that really, when you took those differences into account, it is truly the case that countries that were better prepared generally did better. They had less pandemic mortality. Not all countries. The United States was an important outlier. In fact, there was 8 times the expected level of pandemic mortality in the United States than other highly prepared countries. We need to understand why that is and work to fix that. But it's not the case that preparedness didn't matter. Preparedness is incredibly important. But not just preparing to respond to events when they happen. We'd ideally like to prevent them from happening in the first place. And so we're doing a project, Dr. Wilma James here, a project that we are doing in partnership with the Gates Global Health Exemplars program, working with research teams in Vietnam, in South Africa, and in Kenya and Brazil, trying to understand what would it take to build systems that not only spot outbreaks early so that we can snap into action quickly and stop them from becoming epidemics and pandemics, but what would it take to anticipate when outbreaks may occur before they occur, harnessing what we are increasingly understanding about environmental and climate data to understand when the conditions that are favorable to outbreaks occurring are happening so that we can take action to prevent them from happening in the first place. And there's some really exciting systems that are in place, but we need to understand how they work and what makes them work so that we can understand how to duplicate them in other settings. We also know that it's important to have tools like medical countermeasures, right? We want to have these not just for the threats that we saw in the past, but the threats that haven't yet happened yet. But we also know that the science that's required to make those tools available isn't the only problem to fix. That we need to work to expand access to these tools when they're developed and to ensure uptake of these tools. And so we are working with partners to understand what it would take to do decentralized manufacturing of vaccines, to understand what it would take to scale and deploy and encourage the use of tests so that we can support other medical countermeasures like medicines and therapeutics. But we've also learned that it's not just the tools that matter. Sometimes it's the decision about when and how to use them. And so many of us remember, I'm sure almost everybody remembers, at the start of COVID-19, how incredibly hard it was to get tested. And how not having tests really kind of made us fly blind in terms of our initial response to COVID. In fact, many places that shut down did so not because they were being overwhelmed, but because they simply didn't know where COVID was and how much of a problem it was because they didn't have tests. So tests were really important. Not scaling up testing has been called the original sin of the US response to the COVID-19 pandemic. And some reporting about some of what made that the case highlighted that, in part, insufficient attention was given to testing. In fact, the task force that we're meeting would only spend about 5 to 10 minutes talking about testing. This is a highly technical area for which busy decision makers who don't have deep technological expertise may not be able to ask the right questions that would enable the rapid development and deployment of the tests that we need. And so seeing that these testing stumbles were repeated later in the US response to Mpox, we decided to try to spell out for busy decision makers who may not be fully aware of all the nuances about testing and how different tests do different things and how different testing settings are better able to contribute. We decided to facilitate that by creating a testing playbook for biological emergencies, a sort of decision guide for busy policymakers so that they can be poised to ask the right questions and focus on the outcomes that we want to achieve with tests. I am aware that as I talk about these solutions, many of which involve government, at this moment in time, this may seem like fantasy, that many people are seeing really the erosion of capacities and leadership at our federal health agencies and thinking, what good is all of this now today? I will say, you cannot convince me that the American people don't want to protect themselves and their families. And while the role of the federal government may be changing, there will always be a need for communities to be involved in the work of preparedness. In fact, again, looking at natural hazards, we see a really critical catalytic role that communities play when they are the ones who lead in defining what their risks are and what it means to be prepared and what works for them. And so applying that similar thinking to pandemics, we are working to do just that, harvest the best practices, the innovations that existed at the local level. If you believe the kind of headline narrative that people either thought COVID was a hoax or they just wanted to shut everything down and do nothing else, that is just false. When you get beyond the headlines, when you go into states, when you go into communities and you talk to people, you find that, there were a lot of committed people who were trying to figure out what to do, but figure out what to do in a way that works for them, works for their local communities. And so one of the projects that Dr. Beth Cameron has been leading is to try to understand how can we prepare for pandemics given the democracy that we are. Can we harvest the innovations that existed at the local level and try to understand how to do better next time, to give communities a longer menu of options besides shut down or do nothing. And I'm really proud of the work that's done to kind of profile the lamplighters. These were the people who in red, blue, and purple states stepped up to lead and to innovate, and let's learn from them. Clearly, climate is going to play an important role in the future when we think about infectious disease threats and pandemic risks. It has been playing an important role. This is a really exciting area of science, and I am so fortunate that we have Dr. Rachel Baker at our school, who is really one of the leading minds in understanding how climate is shaping what diseases turn up where and when. And understanding the answers to those questions will help us better prepare for them in the future. Help us better anticipate when they are going to occur, to figure out how best to address them, to figure out how best to protect ourselves. We know that some measures work and some measures don't, but we don't know exactly which ones work and how. And Dr. Alyssa Belinsky, who is a decision scientist, is really, I think, leading the forefront in terms of understanding public health interventions and how best to apply them, including what are the triggers for acting and what data we should be looking at in order to know when to implement measures. Dr. Will Goodell is helping us not forget. He is so much committed to helping us not forget what pandemics have done to us, that he is currently trying to digitize the records, the vital statistic records here in Rhode Island to understand what happened during the 1918 pandemic. This is not just a historical question. There are many epidemiologic questions that we don't understand about 1918, including why was it that young adults were so disproportionately affected? Does that have something to do with the virus, making it unlike other flu viruses? Or was it something to do with the fact that they were returning from war? We need to understand this because to prepare for the next pandemic, we need to know what the right assumptions are. So we need to better understand. And some of what we need to know is in these dusty records that Will has been able to digitize and sense make. And I'm very excited for this project. We also need to redefine public health education. We cannot go through something as profound as COVID-19 with the extraordinary tolls that we've seen and not do something differently about how we train people. Because there's going to be more and more of these events in the future, so we need to make sure that our graduates and people working in the field are ready for them. Dr. Shiloh McBurney is really leading our efforts to try to rethink public health education, making sure that we are cognizant of and incorporating the lessons learned from COVID-19. She's doing this not just for educational purposes here, but also helping the WHO think about how it trains people who will be on the front lines of responding to future infectious disease emergencies. When asked about like what one of the biggest levers for change is in terms of pandemic proofing the future, I cannot say more. Like, there is not possible to downplay the incredibly important role that training the next generation of decision makers is going to be. We need to train people for the realities of the world that they're going to face in the next 100 years, not the last 100 years. And we know that there's going to be more and more of these events, so people have to be ready to respond to them, regardless if that's not their area of focus. If you're going to work in health, frankly, society, you're going to experience one of these events, and you need to be ready for it. But we need to rethink how we train them. We can't just train people in the way that public health is done, where they're just looking backwards to what happened in the past and assume that's what's going to happen in the future. We need to train them to look ahead, look down the road, to lean forward faster, to prevent the worst case scenarios from happening, not just wait for them to happen and then try to figure out what to do about it. And so we have a number of projects ongoing on that, including a course here at Brown, but also workshops that we've been doing in Washington, D.C., and a really historic partnership with many different organizations that are working on this pandemic problem, where we are training people, embedding them in these organizations, giving them experiential learning as well as didactic learning, connecting them so that these organizations have stronger connections, and then basically sending them out in the world to do better. This is going to take all of society. We have to make sure that everyone who needs it has access to life-saving information. So we spend a lot of time making sure we educate and engage with the public. We do that through a lot of interaction with the media. That's an important way to shape public opinion, but also policy lever. But we also do it through other means too, direct education. So we have a monthly webinar series. I really hope you will join us on our next webinar series, but also I would love to involve more of the Brown community in these webinars so that the rest of the world can learn about all the tremendous work that's going on here. And as Francesca mentioned, we started this weekly tracking port. We started this because it became too hard to keep track of all of the infectious disease events that were happening. And I remember getting a call one day from a reporter who I assumed wanted to talk to me about H5N1, but it turns out he wanted to talk about COVID, which was something I hadn't thought about that week. And so to be better prepared for these calls, but also recognizing that many other people were similarly having a hard time staying on top of things, we decided to start this weekly tracking report. And I'm very proud of the uptake and the positive feedback we've gotten, and frankly, one of the highest open rates I've ever seen of a newsletter. So there's a QR code there. I may be too fast. I encourage you to sign up and send it to your friends. We take very seriously the incredible privilege it is to be here at Brown with our extraordinary students. And just like the training of the next generation as being an important kind of lever of change, certainly creating opportunities for our students is one of our priorities. And so we do that in a number of different ways. We have students involved in all sorts of aspects of our work, from our projects to our helping with our classes, trying to connect them to the job opportunities that exist in the field through internships and facilitating placements and mentoring of students. I am truly proud of the work that everyone is doing here, but I think we have to kind of look ahead to what's coming up, and just to say that there's clearly more work that needs to be done. 20 years ago, the National Academies of Medicine held a workshop where they were trying to understand what role infectious diseases may play in the etiology of chronic diseases. It was a really interesting conversation that happened around then. I would argue it is absolutely time to be revisiting these conversations, particularly in light of all the new learnings that we have had during COVID-19. You know, it is possible that one of the aftermaths of COVID-19 is that we could usher in progress in better understanding infectious disease and the harms that they pose to us, not just the direct immediate harms, but the long-term impacts. I think understanding long COVID is an urgent priority, not just for helping the patients who are dealing with that now, but better understanding what this may mean for other infectious diseases. And there is some evidence that suggests that this might not just be this one coronavirus. Perhaps it's not so much about this one coronavirus, but the fact that we had millions of people infected at once that allows us to see things that are harder to see when there's smaller numbers. And while there's maybe kind of talk about we should be taking a break from infectious diseases for a while, I would argue if you are someone who cares about chronic disease, you cannot ignore infectious diseases. That if you care about human health, you have to consider all of the things that affect human health. And we don't yet understand how these things are separate or different in all the ways that we should. I know the prospect of more events like COVID-19 can be daunting, but I am not deterred. I have lots of faith that we can tackle these trends in profound ways, not only to prevent future events like COVID-19 from upending our lives, but I think that this work can help us better reduce the harms that infectious diseases cause, and along the way, deepen our understanding of how the body responds to these threats and what we can do to prevent them and treat them. So we have a real opportunity here, not just to improve life expectancy across the globe, but also to reduce human suffering from a multitude of health conditions. We obviously don't want to live through COVID-19 again or anything like that, and part of our work should be to prevent that from happening. But as a benefit of that work, we can also use it to improve the human condition. And that may seem like far-fetched, but it really isn't, because we've done it before. You know, I've witnessed the remarkable things that the research community has already accomplished since the start of the HIV pandemic. Research that was very squarely aimed at trying to prevent HIV infection, to treat HIV infection, has produced myriad scientific benefits, deepening our understanding of immunology and the body, and how our bodies work, and how to protect our health, how to improve our health in a variety of different ways. Again, I mentioned my husband works for NASA, and NASA brags about all of the things we use day to day that just happen to result because of the race to get to the moon. We have our own kind of moonshot here in HIV, which is just the extraordinary benefits that humanity has achieved as we have worked to tackle the very specific challenge of HIV. So I know we can do this again. It may take a different approach, particularly given the politics of the moment, but it is certainly within our reach. So that's going to take all of us. And here's where I end with an invitation, which is please help us do this. Please come and work with us. We, in April, are going to be holding up the hill, as we like to say, a pandemic affinity group meeting. And the aim here is just to meet each other and to talk about our research and how it may intersect, because I truly think that those conversations are where the innovation happens. So please come. I would very much appreciate meeting you and learning about your work and figuring out how we can do it together. And so I'm going to end there with deep thanks to my Pandemic Center colleagues for all of their commitment day in and day out, but particularly today in help putting this all together. Leave you here also with our various channels that you can stay abreast of our work. And if you'd like to sign up for more of our events with our newsletter and webinars, there is yet another QR code there. So with that, thank you so much. It's been such a privilege to be here.
Questions, and I think we have right here. Great, yes. Yeah, so please, questions.
Yes.
Well, first, I'd like to thank you so much for giving this talk. It was so informative. It was daunting at the beginning, but I think I left hopeful. I think something that immediately came to mind for me is with the COVID pandemic, there was such disproportionate effects on different communities and communities that didn't necessarily have access to the same resources as others. And so looking ahead, what are some ways we can, within preparedness, also look at equity and prepare for that as well?
Thank you for that question. It is a really important one. What you are raising, those disproportionate impacts, is one of the things that when I thought we need to start with the blank slate, I was thinking of. And part of it was that the preparedness community, the people who pushed on governments to get ready for a pandemic, that pushed to develop pandemic plans, modeled in part after things that happened in natural hazards, et cetera. We didn't do it through the lens of health equity and the social determinants of health. And that was a failing. It wasn't that we were ignorant of it. It's just like it got relegated to the appendix. As opposed to when you saw the COVID data start to come in very early on, the disparities were so great that you couldn't help but think, instead of relegating it to the appendix, that should have been the central premise. Instead of just telling base case, average human, stay home if you can to protect yourself, we needed as our first action to say who is at greatest risk of contracting this illness, of experiencing the worst harms, and what resources do they need in order to be able to be safe in this moment. So the equity piece, there's a moral argument to be made, but there is also an operational, pragmatic argument to be made. It's about targeting our resources in the places where they are most needed and not wasting them on the places where they are not. And so I think that when we think about pandemic preparedness, we have to start first with our highest priority parts of our societies, our communities, our highest priority actions, so that we have the biggest impacts.
You've been very effective in the media, both social media and traditional media channels. You're speaking maybe to the students and early career faculty. Any pearls that you can give people who want to be advocates, in that type of way? How did you get started doing that? And can you give any coaching or recommendations?
So I started using Twitter first in 2009 to try to keep up with the news about the H1N1 pandemic. We had a pandemic in 2009. People forgot about it, but I didn't. And I was trying to keep on top of the very rapidly changing situation. So I first started using it. I didn't really push things out. I used it more as like a news feed aggregator. But over time, just started using it more and more. I primarily used Twitter, I say that in the past tense, as a way of speaking not so much to the general public, because I don't think the algorithms truly are open enough for you to be speaking to the general public, though some people do very effectively use social media as a public education tool. That's not been my top priority. I'm more speaking to journalists who are looking for stories or looking for people to quote, or thought leaders, right? I have seen it be an important way to shape a policy conversation. I use it as a megaphone. I don't use it, I never look at notifications. You will lose your mental health quickly if you look at what people are saying back to you. So that's my first thing. The other thing is people have to be kind. And it never looks good to be snarky or attack other people. I think that's the fastest way to lose credibility. And I have seen some really, I think, great minds go down bad paths in that way. So I think it's an important tool. That said, I don't use Twitter anymore because the algorithms have changed such that you can't share links without it being downgraded. And I just don't think it's as effective as it once was. So I'm using other things. But I have already established, the reporters who call me know me, and I've established that. So I think it is critically important. I think it's important to showcase our work otherwise people don't see it. And I can't tell you how many times I have missed really important papers. But if it's put in multiple places, you have a greater chance of seeing it. If it is explained in different places, people have a greater chance of understanding what you're trying to say. So I think it is an important tool for shaping policy, shaping debate. I think it's also an important tool for growing your career, though I wouldn't do that for that reason. I think it's a side benefit of it. And so I have had largely positive experiences, provided you kind of put some guardrails on it. Dr. Jha.
So I will ask a question, but I'm just going to make one quick comment, which is when I arrived here in the fall of 2020, I sat down with Rick Locke, who was provost. And he said, and we talked about faculty that I wanted to try to recruit to Brown, and I said, I have a wish list. And he said, you should send it to me. And I said, I will. And I did. And the number one on that wish list was a brilliant professor at Hopkins named Jennifer Nuzzo. I don't get a lot of things right, but I think I got that one right. And everything you just did in the last hour, I think, proves the point that you have been thinking about this in a way that is very different and very useful in this very difficult space. All right, question. This has always been a super bipartisan issue.
Yeah.
George W. Bush was all over this. It feels less bipartisan than it has ever felt before. What do we do to get that back?
Yeah, thank you for that. And thank you for taking a chance on me, that wish list. It has always been a bipartisan issue. In fact, those of us who work in the pandemic space, a lot of us came out of what was initially the biodefense space, the idea that countries could be attacked with a biological weapon, and we need to get ready for it because the people who are going to be in the front lines are going to be medicine and public health, not just the national security community and defense departments. So it was always bipartisan. It was, something that both sides had. I still believe it is. I think the challenge is in the approach that we took in COVID, in the sense that for many people, pandemic preparedness is now unfortunately synonymous with restrictions. And I'm not going to say that some of that wasn't necessary. I think we actually did a lot too much. But that should not be the goal. I mean, the public health, the ethos is by the least restrictive means necessary, right? And so I think what's going to have to happen is more of the bottom-up approach, whereby communities get to lead the conversations. And they're going to lead those conversations based on whatever local priorities they have. Maybe it's not pandemics. Maybe it's the effect of climate change, the flooding, or the whatever. But leading the conversations about what it means to be ready for sort of these no-notice emergencies that potentially are pervasive and protracted, and then define for themselves what works. Now, that is not going to be a replacement for federal leadership, federal coordination, federal funding, but it starts there. And I think as it builds up there, then hopefully we can get back to this point where it is less of a third rail politically and more of this is what the communities are asking for. But I think, and you know this because I know you have these conversations, when you talk to people, there's a lot more common ground than they may be saying on the late night cable news shows. And so I think it's about prevailing to those areas of common ground in those conversations as much as possible.
Thank you, Jennifer. Very nice talk. Jennifer, how do you sort of keep this in the window, or in the how do you sort of elevate this so this is has a funding focus still, and because it seems like once the pandemic was over, people felt like, well, that's again, like as you articulated, it's once in a 100-year event, but everything you talked about with respect to preparedness and response and putting people in situations where they can quickly react suggests kind of a sustainable or sustained funding. So how do you sort of put this in the eyes of the potential people who actually fund this kind of work?
Thank you, Ron, for that question, and thank you for really your enduring support. The week that I came to Brown was Ashish's first week at the White House, and one of my first lunches with leadership at the school was with you, and you were just so immediately supportive that I felt reassured that this was the right decision. So thank you for that. And you always show up to all of our events. I'm very grateful for that. The funding situation is bad. I'm not going to sugarcoat it. It is bad. There are a lot of bad things happening right now. I have seen over the years the whatever you want to call it, panic, neglect, crisis, complacency. That is common. I do think the moment we are in is profoundly different than any other time. I will just say that the hope is that we can make these changes before the next event occurs. But even if we don't, the next event will occur, and there will be a need to respond. There will need to be a react. So what we have to do in hopes that we can do more before then is to show people why it matters, what the impacts are, what the measurable outcomes are, what the benefits are, what the cost savings are. There was I didn't show it in the slides, but I had considered including it. There's a Lancet commission that looked at a large group of people investing in, looking at what the costs of pandemics are relative to the other high burden infectious diseases, and found that, unsurprisingly, the costs actually exceed, both in terms of human impacts and economic impacts, what these high burden diseases are that we very much need to invest. But we can still invest in the high burden diseases and have it have impacts for the no notice pandemics, that the systems that we want to build can function, whether it's the flooding in our town, needing to make sure that we have the abilities to communicate risk and a variety of other things. Many of these things are durable and flexible such that they can be used for day-to-day events. Of course, there are some that will have to be there for emergencies specifically, but I think, and this is where really I think research community will play a role in showing the return on investment, showing the cost effectiveness of these approaches. Will that be enough right now? I don't know. But I do think sooner rather than later, we are going to see, again, what complacency costs. And, this, there are unfortunate that the frequency of the reminders is great. We had a conversation actually last week at our event, the 5-year anniversary, about the kind of polarization that we're seeing. To some extent, remind ourselves that at the start of COVID, Americans were largely all in support of what was happening. But over time, that support eroded, but it eroded differentially based on your politics. This level of polarization we're in is partially the luxury of having forgotten where we were 5 years ago. I am struck by the fact that in responding to measles outbreaks in West Texas, when they offer vaccine, people are taking it. When they see the need, they see the need. So it's my hope we can do more before that, because we don't want to lose people that we could have prevented the loss of. But these things will come back whether we want them or not.
First, thank you so much for all the work you're doing and for the talk today. I guess I want to come back to the political question. If the lesson from COVID is a more bottom-up response, that's a huge organizational effort to train and prepare people to have those conversations at the community level, whatever the community level is. And I'm just wondering where one goes to kind of build that capacity. Is it state governments? Is it city governments? Is it a combination of the both? Are we thinking about the infrastructure for developing the facilitators of those kinds of conversations?
Yeah. So what I'm saying about this bottom-up approach is actually not a new idea. In fact, 20 years ago, when we were very worried that we could have an H5N1 pandemic, and one of the scenarios that President Bush was very worried about in directing multiple federal agencies, 17 federal agencies, to develop pandemic preparedness plans, triggered in part by having read The Great Influenza by Brown alumnus John Barry. That book actually he credits as sort of helping him see the importance of getting prepared for pandemics. His Secretary of Health, Michael Levitt, was sort of famously quoted as saying, listen, when a pandemic happens, states, you're on your own. Federal government's not coming to help you. And it was kind of shocking because federal leaders don't usually say that, but it was sort of true because in a pandemic, there's a lot that can be done, but there's also not everything. And so his direction to the states was, listen, states, you have to get ready. You have to start doing things. And what we saw at that time was some really remarkable attempts to engage not just the public, not just community-based organizations who would likely be tapped to help support the work of states, but private sector, lots of different organizations, to the point where there were even focus groups being conducted in states to say, listen, if we have too many patients and we don't have enough ventilators, who should get the ventilators? So really a truly engaged process to try to better understand if a pandemic happened, what should we do? We have forgotten a lot of that, but just to say that we've built that infrastructure in the past. I think it has to start with states because that's reasonable, but I think there are some cities that are going to do things on their own. And one of the projects that we're doing, and please talk to Beth Cameron about this, is to engage through governors and private sector organizations, including the U.S. Chamber of Commerce Foundation. We're actually trying to pull them together on this topic of H5N1 very soon because we want to seed that, create that impetus to start those planning yet again for another pandemic, with hopes that this time we won't forget.
So we might have time for one more question, if there is one. I thought I saw one over here. I didn't want to put you on the spot if you wanted to track your question, but that's
Hi, fantastic talk. If there's any students in here and you have not taken her epidemiology of infectious disease class yet, I totally and highly recommend it. She's a plethora of knowledge. But I had a very just broad-reaching question, so we've talked about this in class, but I guess for the purpose of what we're talking about right now and what's been alluded to, we're in an era of misinformation, and we have a lot of, young professionals who are going into the field now, who are going to be going into the field, and there's a lot that we're going to have to combat in that trail. How can students and early career professionals prepare when we get out into the field and we're all trying to do what we have been trained to do and what we have learned to do and what we are loving and putting our passion towards? What can we do to make sure that we are continuing to pandemic-proof the future, but also combat a lot of the misinformation and also the vaccine hesitancy, which has resulted in some of these new and re-emerging infectious diseases?
Yeah, so thank you for that, and extra points to you. Very heartened to see some of my students here. It's very gratifying. I do have to say that times feel a little tough these days, and some days it's hard to summon the motivation. And walking into the classroom and seeing all of your bright, enthusiastic, and just ready to take on the future faces is therapy for me. So thank you for giving me that. This is a tough problem, and I am extra glad, thanks to Dean Jaw's leadership, that we have here at the school Information Futures Lab that's actively studying this problem to understand the information environment and how it works and how best to address mis and disinformation, as well as try to work at the community level to overcome these things. So just to say, I think this is an area of active research. I am not expert in that. I have come to observe some things empirically through the conversations that I have gotten to have over the course of the last 5 years. And I will say that the lessons that have jumped out for me is, one, the critical importance of empathy. Two, listening as much as you're telling. I think some of the early evidence shows that trying to convince people is not the right way, but listening to people and their concerns does seem to have more of an impact. I think as a field, we need to learn how to do public communication better, because we have, in public health, when we think about risk communication, we are obsessed with distilling facts and making them more accessible to a lay audience, as opposed to communicating with people about something that's ultimately tied to their feelings. And I think that when you're talking about how you reach people and change their feelings, that is where the arts come in. And so one of the things I didn't include in the slides, but one of the things that we've been doing over the last year in partnership with Brown Arts Ignite is a project called Our Storied Health, where we've been exploring the use of storytelling and narrative. We've been watching films, and we have been trying to understand how films communicate to us and whether we can employ those lessons in how we communicate with others. The other thing is that think of yourself not just as a scientist, as a practitioner, as a public health person, but think of yourself as a family member, as a friend, and as a community member. And that is where people, the evidence that I have seen shows that that's who people listen to. They listen to people in their communities. So employing some of these tools like storytelling, narrative, et cetera, is great. And I just read a paper today talking about how debunking does not work online, but possibly directing people to other aspects of the problem. So anyway, just to say, more to come. I think this is an area that we should do absolutely more research. But I do think this is an area where we need some new strategies for sure.
Well, thank you very much.
Thank you so much. Thank you. I really appreciate it.